Hello, everyone, and welcome to our latest podcast, WADEM podcast series. Today, we're going to be talking about coronavirus, which is sweeping the world, has been declared a pandemic by the World Health Organization. And speaking to us today is Dr. Greg Ciottone, the president of WADEM. He's got over 25 years' experience as an emergency medicine physician. He works as an associate professor in emergency medicine at the Harvard Medical School, and he's well experienced in disaster medicine, having practiced it for many years, and is well recognised as a global leader in disaster health practice. So welcome to the podcast, Greg.
Thanks, Joe. Thanks for having me.
No worries at all. We're really looking forward to hearing some of your insights today. Maybe just to kick us off, what's your perspective of the current impact of COVID globally?
Well, as you know, we're now a couple months into this outbreak, starting in Wuhan, China, and now spreading globally. We, I think, have seen the kind of spread globally that we somewhat predicted as we started to understand more of how this virus acts and behaves. So we are seeing the global spread. As you know, just a few days ago, WHO did call this a pandemic, which means there's pretty much broad community spread of the disease. So I think that we're going to continue to see spread. We're going to continue to see cases. The community spread probably will eventually become more ubiquitous, and we're going to have to really concentrate on efforts to mitigate that spread on a community level, as well as to prepare healthcare systems to handle the surge of patients that will be coming.
Okay, then. So it's a new disease. We're coming to grips with it. What gaps do you see in the data around it at the moment? Is there any sort of areas we should be concentrating in, or any particular key points that we need to focus on as a medical and research community?
Well, I think one thing we have to understand as we look at the data is that we are rather early on in the outbreak. And being a novel virus, a new virus, most of what we know has not really been very evidence-based yet. We're starting to get some evidence in. So we have to understand that we need to look at the data and, of course, act on the data that we have, but that data may change. So, for example, right now it appears that if you get the coronavirus, about 80%, maybe a little bit more, will have just relatively mild flu-like illness symptoms, and will be able to recover well at home in self-quarantine or trying to self-isolate. Somewhere around 15% will require hospitalization, which really includes supportive care and supplemental oxygen. And then it looks to be about 5% at this time will require ICU care. And that's really where most of the strain is going to be put on the system, is that ICU care. But again, these numbers, the 80% mild symptoms, not requiring treatment, much in the way of treatment, 15% maybe requiring hospital-based treatment, and then 5% maybe requiring ICU treatment, also may vary as we progress through this disease, because it's early on and we don't really have the opportunity now of really understanding it much like we will in the future when we get past this pandemic and are able to look back and analyze the data more completely.
So in that space where we're sort of dealing with an unknown and a new threat, there's quite a lot of talk either on media or on social channels, etc. And there's a predicted significant impact on health systems around the world, and we've seen that evolve already in some countries. Given that spread is still occurring and some countries are yet to feel the extent of that impact, what do you feel are the key activities that healthcare systems should be undertaking to maintain capability as it spreads?
Yes, well, you're correct in that in a couple places in the world, we've seen the impact of this pretty dramatically. Of course, China had a pretty dramatic impact of the disease early on, and now we're seeing the impact in Italy and some other countries. So I think this is a good time for the healthcare system in countries where the impact has not been that great yet to take a good look at what is going on in these higher impact areas, and do the things that need to be done to begin to prepare. Now, of course, we all hope that our mitigation strategies, mitigating the spread of the disease on a local level, will assist us in blunting that curve, as we say. And blunting the curve simply means that if, let's say, 100 patients are going to get coronavirus, I'm just using these numbers haphazardly, but if 100 patients people are going to get coronavirus, let's try to make it so that 100 is spread over time and they don't all present to the healthcare system at once, because that will then put a strain on the healthcare system that is, going to be very difficult to handle the surge. So when you hear this idea of blunting the curve, that's exactly what we're meaning, is to try to mitigate spread to the point where if somebody is going to get coronavirus or a number of people are going to get them, let's sort of, spread that out. So to answer your question, though, what healthcare systems should be doing now is taking a good look at themselves. Hospitals internally look at themselves, healthcare system take a look, and start to plan out what we might do in the event of a surge of coronavirus patients. And at certain steps, at certain levels of patients that we're caring for, what steps do we need to take as a healthcare system? So what do I mean by that? Some of these steps could be looking at areas of the hospital where you can consolidate and start either not doing, let's say, elective procedures, reallocating other spaces in the hospital so that you can then increase your inpatient bed capacity and also increase your ICU capacity. You can also look at if you're getting a flux of patients in to the emergency department, or at least into the hospital, who are looking to be tested. Some of the steps that you see being taken now around the world is to push that testing off to another site. So here in the United States, there's been a move now to start looking at large retail parking areas where we might be able to do, as we say, quote unquote, drive-through testing of people who are well but might have some sick contacts or some concerns that they'd like to have tests done for. At the same time, people coming and presenting to emergency departments really shouldn't be clogging the emergency department by coming in and being assessed as in a normal situation, patients would be assessed in triage. Instead, what we should be doing is setting up a screening area someplace nearby but outside of the emergency department. So patients who are well, of course, if you're sick or ill, you need to come right to the emergency department and right in to be treated. But if you're well, can be screened somewhere away from the normal ingress to the emergency department, so that you don't we're better able to handle, again, that surge. But to look back at the hospital now, what I think many hospitals are doing are looking again internally at their own systems, the number of beds, the number of ICUs, and other things to then determine what steps are going to be taken if and when these surge of patients that need to be cared for in hospital occur. And at certain levels, what do we do? So one strategy for that is to identify, near to the hospital, somewhere around the hospital, areas that you can use as what we call alternate care sites. And then some of the preventive care, primary care, and some other things, because as you know, these pandemics, they last sometimes for months. So this pandemic right now may last for weeks, may last for several months, or maybe even a little bit more. We don't quite know exactly how it's going to behave yet. But over that period of time, hospitals and healthcare systems still need to care for the patients that they routinely care for. Patients have chronic illness, they have diabetes, they have cardiac disease, respiratory disease, other things. Those patients still need to be cared for. So some of that non-urgent care can be pushed out to alternate care sites that are pre-identified around, let's say, the hospital, and then retasked to do this, to provide this care as opposed to everyday function. Now, that may not even be areas that are in the hospital. There are some hospitals, especially urban facilities, that are near to some infrastructure that might actually be conducive to this sort of alternate care site. If you have, let's say, colleges nearby, or other areas that have larger rooms or places that you can retask for this sort of provision of care, these might be areas to look at and see if you can't establish relationships to do that. So in this time right now, when we know that COVID-19 is present, It's global. It is a pandemic. But if you're in a situation where the surge really hasn't come yet, this is the best time now to prepare your healthcare system, to prepare your hospital for that surge should it come.
Okay. So you mentioned before about blunting the curve and putting in place strategies that spread or delayed the impact of COVID when it does arrive. And there's a number of strategies that different countries are undertaking to address this. Which do you perceive to be the most useful of these, and why?
Right. So this now gets into an area of the mitigation of the spread, essentially. So when you're early on in an outbreak, in any outbreak, and there's just isolated spots, whether it's where it originated or let's say in your country or around the world, those are when there's the isolated areas of infection, those are very conducive to the idea of containment. So that idea, we see this with Ebola outbreaks all the time. When in Central Africa, for instance, historically, for many of these different Ebola outbreaks that we saw starting from the 1970s, the country and WHO and other factors worked very quickly to come in very early on and contain it, meaning you quarantine and isolate out the area, the small area where it is, and you try to contain it so it doesn't spread outside of that. What we saw with Ebola in 2014 and 2015, when it spread into West Africa, is that the infection and the spread got a little bit beyond the containment efforts, because it wasn't, different factors, and we saw more of a spread in Western Africa. Yet we were still able to contain it. It didn't spread further than that. For coronavirus, which is more transmissible than Ebola was, that early steps of containment should be done if there are just small numbers of cases, let's say in a country or an area or a region, to try to contain those off. If there are hotspots in the world, trying to limit, movement into other areas from those hotspots are a good thing to do. But what's slowly going to happen over time, and this is, we're pretty much getting into this now, is that the community spread is going to be so global and so diffuse that the ideas of trying to ban, let's say, travel or commerce or anything else from specific regions with this idea of keeping it out will not be as effective, because we have community spread already within. And then we transition more into the idea of mitigating spread. Now, we should be mitigating spread from day one, no question, but we start thinking more about mitigating the spread. And what do we mean by that? So you've heard a lot about social distancing, washing your hands thoroughly and often, use of sanitizing, solutions, coughing into a tissue and throwing that out or into your elbow. All of these sort of personal hygiene steps are very, very important for blunting that curve and mitigating that spread once we have community transmission of this disease, which I think in many parts of the world we have now. So that's why you're seeing closures of many mass gathering events. You're seeing some closures of schools and colleges. You're seeing some other steps being taken to limit the situations where a number of people are gathered in one place. And I know that's very disruptive to societies, certainly is. But at this time, for a short period of time, it's probably a necessary step to limit the spread of this disease. That, and also quarantining or self-quarantining ill. So if you're ill, and you may have the COVID-19 virus, maybe you've been tested, maybe you've not, but there's enough suspicion that you do have that, you should be home and you should be self-quarantining for at least 14 days. And this is going to prevent the spread of the disease as well, so that you're not into areas where you're spreading it into others. So if we all think just for a moment, imagine in a utopian world, okay, where the entire population, every single person in the world, is able to be educated, so public education is fully effective. They understand what they're supposed to do for personal hygiene and self-quarantine of the ill, and they actually do it. So imagine this utopian world where every single person practiced the personal hygiene and also self-quarantined if ill. This disease would be nearly stopped in its tracks within a couple of weeks. But of course, we don't live in a situation like that. So the best thing to do really is to promote public education, to really, have people hearing this over and over and over again, that the idea of social distancing, be at least 2 meters or 6 feet apart from others, if you can. Do the hand washing, do the using the sanitizing solutions. Make sure when you cough or sneeze, it's in a controlled setting, into a tissue or into your elbow again. Taking these steps will go a long way to mitigating the community spread.
Okay, so good advice, Greg. What I was thinking earlier is we often talk in emergency management about planning for recovery right from the start. Now, it might feel, I guess, a little premature to be talking about recovery from coronavirus already, given that the impact is going to be likely occurring over a period of time. But from your perspective and your background in disaster health practice, what are your thoughts on what signals we should look for regarding recovery? And do you have any suggestions on how we should be planning for recovery post-coronavirus?
Yeah, so recovery is going to be an interesting topic as we move forward. It's something obviously we're all going to be moving into in an undetermined amount of time, sometime soon, hopefully. But the recovery is sometimes hard to actually put your finger on that. Yes, we're now in the recovery phase, and some of the things to look for in that sense are numbers of new cases. So the transmission of this disease hasn't started to fall off, and one thing that might actually influence the decline in this community spread and transmission is actually the number of patients who have gotten the virus and then recovered. Now, the data is still out a little bit about what kind of immunity you have after you have the virus. In many cases, when you have a disease like this, an infectious disease, and you recover after having the symptoms of the disease, and now you're recovered, you have some degree of immunity after that to getting that disease again. And that can last anywhere from a year or more to much shorter times. And we just don't quite know right now with COVID-19, if and how much of that immunity is set up in somebody once they get it the first time, and hopefully never get it again. But what kind of immunity happens, and then how long will that immunity last? So that's, again, a little bit up in the air. But assuming there is some immunity after getting the disease, what that does is actually decrease the number of people in the population who are then able to transmit the disease. So it's sort of a natural blockade to community spread. So we're going to see that start to influence the spread of the disease as well as time goes on. So there's going to be a number of different factors, and I think probably the best thing to evaluate and to judge as far as are we in the recovery phase yet or not, are the number of new cases that we're getting. Do we see places where new cases are coming down? And I believe that we're starting to see this a little bit in China and perhaps in some other areas. So once the numbers of new cases start coming down, I think that we can pretty safely say that, okay, it looks like we might be entering the recovery phase. Now, from a personal perspective, it's still a little bit up in the air. I don't think that we have come up with a really good plan yet of exactly how, if somebody does self-quarantine or self-isolate for, let's say, the 14 days, how do we know when they can come back out into society and not, be transmitting the disease? That's a little bit up in the air right now. The thought is that we may still be shedding virus after symptoms go away for maybe another 2 days. Maybe it's more than that. We don't know. And maybe there's been some what we're saying now is, or the idea that we have now is that if you self-quarantine and you get better, then you should have 2 COVID-19 tests, at least 24 hours apart, that are both negative, and that says now that, okay, you can, come back out and go back to work and do whatever. I'm not sure we're going to stick with that plan. We may modify that plan based on new data that comes out. But, that's the general philosophy, is that if we start seeing a drop in cases in the community, we probably are starting to enter into this recovery phase. And then as far as personally, your symptoms go away, we have to figure out what's the appropriate amount of time after that you can then, rejoin society, as they say. But to be honest with you, one I think benefit from this pandemic, this outbreak, is going to be that we better understand the transmission of disease as a population, as a people, and we start maybe doing a better job of personal hygiene. We start adopting better practices of how to, prevent infections in general, from getting infections in general. I think coming out of this outbreak, this pandemic, I think people are going to be a lot more thoughtful about washing their hands, about coughing and sneezing the correct way, about doing all these things that we should be probably doing to a certain degree all the time, so that we don't get infections.
Great advice again. Thanks so much for your time today, Greg. It's really important that as we're all in this together as we battle COVID-19. So the more we share information, the more we can all learn and do our best as a community to take this head on. So thanks again for your time. Hopefully we can have you back for another podcast on this topic as we move through it.
Yes. Well, thank you, Joe, and thanks for the time and having me on. If I could say one last thing, just as a general statement, I think that we as a people, again, as a global community, need to follow the data closely that's coming out of, let's say, WHO and CDC and other reputable organizations like that, and use that data in an educated way so that we try to limit panicking. Panic is never a strategy. It's never good, and it's something that we try our best to avoid in emergency management. And I think by being better informed, by using the data that we're collecting and analyzing by experts and understanding that, and hearing that from our leaders and from the press and from others, I think we then take a giant step towards a practical, evidence-based, educated approach to how to respond to this pandemic, as opposed to panic. So keeping an eye on WHO and CDC and some of the information that comes out from those areas, I think is very important, so that we as a global community can get through this pandemic as rapidly as possible.
It's good advice, and it's a really good space for healthcare leadership to step into, because we've all seen the amount of media and chatter around COVID, and what we do need at times like these is clear direction and leadership to help guide us all through it. So thanks very much for that, Greg.
Yep, thank you, Joe.
Okay, take care, and we'll catch up with you soon. Thanks very much. Bye-bye.
Bye-bye.